Hi, I'm Tim Sweeney, CEO of Inflammatix. I'm here today with Dr. Nathan Shapiro, Professor of Emergency Medicine at Beth Israel Deaconess Medical Center and Vice Chair of Research in the Emergency Department there. Dr. Shapiro, tell us a little bit about yourself, your background, and your research interests.
Hi, thank you first for having me here today. My name is Nate Shapiro. I am an emergency physician at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and a professor at Harvard Medical School. My research interests are sepsis, diagnostics, and treatment. And this really spans across a portfolio of interests from biomarkers to the best way to resuscitate a septic patient. Thank you.
As an emergency medicine physician in the Northeast, you were part of the first wave of COVID-19, and by now you've seen more COVID-positive patients than most parts of the country. Can you tell us some about your experiences?
Sure. So in very broad strokes, the disease has been interesting in that there seems to be about a week or so prodrome of viral syndrome, flu-like illness, followed by the patients either getting better or getting worse and having a respiratory component be the real driver. So a lot of times patients will have been sick for a few days and then present with a respiratory illness when they start to head into a critical phase. One key feature I think has been discussed a lot is the degree of hypoxia and in many cases asymptomatic hypoxia. So what we're seeing is the disease really attacking the lungs and that being a key feature. And so the patient is in their progression, which can often happen very quickly, is one of the hallmarks. Of course, there's also the thrombogenic portion of the disease where we're seeing strokes and other bad things that are consequences of this thrombogenic component, as well as some cardiac component. But in general, the driving feature of critical illness tends to be the respiratory component and hypoxia.
We've heard a lot of words and terms used to describe severe COVID-19. Is severe COVID-19 viral sepsis?
In general, it's viral sepsis. In general, it's a virus that's causing a patient to become systemically ill. That being said, it has been striking. Again, I'll go back to the respiratory component of this, in that really seem to be affected primarily, as well as the thrombogenic component and some clotting that occurs. But the flu, which tends to function more as broad sepsis, here we're seeing a little bit more of targeting of the lungs with this.
Good. How do you predict which patients are going to become critically ill? We know that, for instance, older patients, more comorbid patients are more likely to become sick. Is that enough?
So clearly that's not going to be enough. We know that patients who are frail, older, have high comorbidities, just like any illness really, are likely to be the ones who are going to become more ill. But there's also patients who are perfectly healthy who have a really severe and sometimes tragic course. So being on the front line and especially assessing patients in the early stages and trying to get a feel for which direction they're going to go is a real challenge. Now, part of the challenge to us is we just all don't have that much experience with this illness. It's all less than 6 months old. So really trying to decide which features are going to be the things we should be paying attention to is really important. And we're accumulating evidence. Some of the initial hallmarks of disease that were, say, reported out of China in the first couple months, such as low lymphocyte levels, ferritin levels, CRP, in some cases, it's consistent with patients with more abnormal levels will do worse. In other cases, it's just not. So I think we're still searching for ways to best risk stratify our patients. And I think this is an unmet need that's going to help us to really identify the patients who need more intensive therapy, as well as potentially to select patients for more novel or more expensive therapies as they become available.
So let's take those two things separately. Maybe the first is patient factors. We've seen numerous manuscripts now with machine learning algorithms that look at things like vital signs and lab data to predict patients with poor prognosis. What do you think of that approach?
So, I think we have to be careful, and part of this era of COVID has been the research has been moving so quickly, and stuff is not taking the time we need to with some of these things to really vet it and make sure we maintain methodologic rigor. So when we get into machine learning, part of it is this is really the derivation of that in many of these studies where we're taking an initial set of data, we're applying machine learning and looking for maybe some more complex relationships, and oftentimes overfitting the data, coming up with models that probably aren't going to be reproduced.
Mm-hmm.
The other tricky part of machine learning is that how do we implement it? So in other words, if you take a very complex data set with a lot of covariates or features in the machine learning world and create these complex models, how do you then take those models and implement them in the hospital setting? So you have to get inside of the architecture of the system in order to gather everything and then present the information to the patient as they need it. So overall, while I think machine learning has great promise and having computers identify relationships and patterns to predict patients that the human can't see is quite attractive, but when the reality of implementation occurs, there's a lot of caveats before we can have a lot of fidelity in these kinds of approaches.
Okay, so if machine learning algorithms aren't a major part of your practice today, what about the biomarkers you mentioned? IL-6, ferritin, CRP, do you use those clinically for risk stratification in your COVID patients?
So it's a great question, which is how do we risk stratify our patients? The truth is, we'll look at these things. So we'll look at CRP, we'll look at ferritin. Personally, I don't have access to IL-6, so that's not part of our practice. I think a general inflammatory biomarker helping to inform decision-making makes sense for those people who have it. But just kind of taking a step back, any single biomarker strategy is likely to be looking at too narrow of a spectrum of a very complex and heterogeneous disease. So if we're looking at IL-6, we're looking at inflammation. Inflammation is important in the COVID illness. So that's helpful, but it just doesn't tell the whole story. And so I think that single marker strategies are always going to be limited by the fact that you're looking at only one aspect of a very complex interaction of the disease state.
And what about clinical performance? IL-6 in its EUA was noted to have a performance for predicting the need for mechanical ventilation, sensitivity of 84%, and a specificity of just 63%. Is that good enough? And if not, what would be the criteria for clinical actionability? Yeah,
so in general, as we apply these biomarkers, I think there's two ways to think about them. One is you can look at the performance in isolation. And something with 80% sensitivity, so you're going to miss 1 in 5 with the disease, and you're going to overcall it about every other time. It depends how you're applying it. I guess it's a little bit helpful. I think what we need to do is have our clinical approach or clinical judgment have these biomarkers help. But the problem is when they don't have high enough fidelity to really drive decision making, then they're just an adjunct that's often a distraction. So I think we really need to call upon biomarker strategies that are going to really give us enough fidelity to be able to change our decision making and make it in a positive direction and make it better. So I think we need to demand more from biomarkers before we can say that they're really going to impact clinical practice in a positive way.
And what about outside of clinical performance? Is there any thing like turnaround time or workflow needs that you think of when you're thinking about a novel biomarker being implemented in the emergency department?
Yeah, of course. I mean, we have to, the actual clinical practice and implementation is key. So turnaround time, depending on what decisions you're trying to make, has to be quick within, within 30 minutes is ideal. Within an hour is probably acceptable. Once we start getting beyond that, it's a little helpful, but a lot of times the clinical pace, especially the clinical pace of the COVID-19 disease, is going to move faster than the biomarkers. So if your biomarkers are telling you, how the person was 10 hours ago, because that's when they're coming back, that's probably less helpful. So it needs to be quick. It needs to be able to be run by a lab, either on equipment they already have or as a standalone device, or it has to be run at the point of care, which as technology is moving forward, this is becoming more and more feasible and attractive. And I think, so a fast test connected at the point of care to a given patient, this starts to become quite attractive.
I'll take you back to something you said earlier, which is that single biomarkers may not be informative of the complexity of an immune response. What do you know, I guess, can you summarize in your own words what we know about the immune response in COVID as of today?
So I'm going to say I'm going to go with the host response. I'm going to twist your question a little. So the immune response, we know, tends to be quite robust. It tends to be a hyperinflammatory state. And we think that this pattern of hyperinflammation in general is what's causing a lot of the ARDS, organ damage, and a lot of the problems. But there's also other components of the crosstalk of the immune response. So the thrombogenic portion, the endothelium looks to be a real central player in a lot of this. And my guess is the epithelium as well. And so it's a lot of the crosstalk happening within a person as they're getting sick or sicker that we're trying to understand where they're at. And so I think the real challenge is to intercept and interpret this crosstalk in order to know the best way to assess a patient and in order to prognosticate where they're going.
Great. Let's maybe change tacks for a minute, if you don't mind. As you know, we at Inflammatix are developing a new kind of test or a suite of tests that use machine learning and bioinformatics to interpret complex immune responses, just like you say. And in particular, we look at multiple immune mRNA markers from blood. Our initial assays, as you know, are going to identify the presence or type or severity of acute infections and sepsis. And I'm just wondering for the audience, maybe you could tell us a little bit about why you've decided to work with Inflammatix as a clinical collaborator and as a national PI on our Sepsis Shield trial.
Sure. So I've done a lot of biomarker work. Much of it has been single biomarker work, and it's all been almost exclusively protein-based biomarkers. So really the proteins that are being released in the blood try and pick off one signal or the other. I've done some multi-marker work, but the problem was there was no way to actually operationalize it, or those operationalizing techniques are just evolving and tend to be limited to a couple protein biomarkers. I think something that's really interesting about the Inflammatix approach, or two things, two primary drivers that makes the technology really interesting in my mind and have a lot of potential is, number one, it's looking at the transcriptional signal that's being given off. So it's really asking the question, not what are the proteins that have been made, but how is the immune system responding? So what proteins is the immune system trying to make? Number one. Number two, the capacity to run many of these transcripts, or to assess multiple transcripts simultaneously, is really attractive, and to change that portfolio as the data informs it. So these are the main things. And then finally, the fact is, when we get back to just practical feasibility, the fact that there's a point of care device that can operationalize all of this, to me, is what really positions Inflammatix, or companies like Inflammatix, in an interesting and valuable spot.
That's great. That's great. And thank you. We are currently developing an assay specifically for risk stratification in COVID-19 called Coverity. Coverity is a molecular assay which will measure 5 mRNAs from patients' blood to help predict severe respiratory failure and eventual need for mechanical ventilation. I'll ask you a hypothetical. If the assay is proven to have strong enough accuracy to predict mechanical ventilation in your ED patients, and we can turn it around in 30 minutes, how would you be able to change your practice?
So I think really just like any biomarker, if we're talking about for the emergency department, I think there's some critical decisions we make, but perhaps the kind of most critical decision is how to progress the patient through the system. So if we think in broad strokes, should we send the patient home? Should we admit a patient to a hospital floor? Should we admit them to the intensive care unit? And what level of therapy do we anticipate they'll need? And so I think a severity marker that can help guide us in saying these patients should be at low enough risk for overt decompensation that they can be managed at home because because we need the beds and as hospitals are filling up, over admitting is really not helpful. Can the patient be managed in the floor because they could need some critical care? It could have some critical care needs or could get worse, but that's less likely. Or do we want to put the patient in the intensive care unit because the likelihood of needing critical resources is very high or high enough, and patients crashing on the floor always leads to worse outcomes. So I think a biomarker system or a risk stratification tool that lets us help decide severity based on those will help us to make better decisions. And I think the first and foremost decision is really patient triage.
That's great. Well, certainly we'll have to prove it with clinical data. We'll post a preprint of our first prospective validation pretty quickly, and actually the contents of our next webinar on this series for the SAEM will be presenting this validation data. Of course, we'll have more to come soon thereafter. Nate, thank you so much for speaking with us today. And to everyone at home or at work watching and taking time, thanks so much for your attention as well. If you'd like to connect with us at Inflammatix to learn more, to collaborate clinically, to be an early evaluator, please feel free to reach out to us at any of the channels you see on screen. Thanks very much, and we'll see you next time.
Great. Thanks for having me. Bye-bye.